So what have I learned and what am I still learning? Well, I have to once again refer to this study of Mike McKee's, which is so impressive, randomized control series, with clearly shows in an older person, patients do very well with the total elbow. Importantly, in this study, you should notice that there were 5 patients that crossed over from ORIF to total elbow. So the outcome in the total elbow actually was a more difficult group. And still, the treatment of choice for the older community is total elbow. What's old? Who knows? What's young? Who knows? It's your attitude, clearly. And it goes a lot to what's the nature of the injury. A lot of it has to do with restrictions as well. Of interest, a study we did a while back showed that of the patients that had total elbow, 95% engaged in moderate activity, 40% heavy activity. And what's really interesting is most of them thought, I don't know if you can see that on your screen, but most of them thought that they were following instructions. So when you talk about telling persons to have restrictions, you got to understand that they don't necessarily listen. What kind of an elbow are we talking about? The implant should be flanged and should be, of course, with a linked and a sloppy type hinge. What about length? Well, at one time we thought that the 4 and 6 inch lengths had the same outcomes because of their survival, but then we found and did a little more analysis and found that the shorter stems failed within 3 years and the longer stems took 7.5 or so. So we do think that the younger patient with a total elbow for fracture should have a longer stem. We do try to keep the triceps intact as far as technique goes. The key is once you resect all the fragments, it's an easy operation. You don't have to take the triceps down. We'll talk about some of these other components in the professorial lectureship. Except I do want to mention soft tissue tensioning because I've seen this as a mistake. If you lost track of what your length is, you should try to restore soft tissue tension. Otherwise, you'll get a soft tissue wad in front of the elbow, and that will pull the ulnar component out of the ulna. And so there is a way of doing this, which we call the Shuck test. We articulate the trials, and then we see what the tension is front and back, and then that's the depth of insertion of the implant. We did look at our 10-year results, which minimum 10-year results going up to 23-year results, 44 procedures, because the real key is how do they do long-term? And surprisingly, they actually did quite good. As you see, 83% of the patients still had their implants intact with no additional operations at 15 years. What happens if it fails? Can you salvage it with the total elbow? You can always do the total elbow idea, and that just needs to be rejected. We did a study to find out if there was a problem with going back in on a failed ORIF within a year. And it turns out the MEPs were the same in the 2 samples if there were no complications. The problem is there were statistically significantly more complications, both reoperations and revisions with the patients that first had an ORIF, it failed, and then they had the total elbow. So what is our experience overall with the younger population? Well, it was mentioned that Michael, I think, mentioned that the rheumatoid patient had the fracture and had total elbow. It turns out in our first early series, we had twice as many inflammatory patients with fractures as trauma without an inflammatory condition. So we selectively were picking those people that already had arthritis and then had the fracture in the early years, at least. We followed these patients for about 7.5 years. And actually, you should know that we did 130 interposition arthroplasties in this period, which means when we're operating on a young patient, we felt that was the only solution because we did do a lot of interpositions during the same time period. So what was the outcome? At the end of 8 years, 91% were doing well. These were under the age of 40. Inflammatory, almost all of them. In trauma, about 85%. And so we would conclude, fix if you can, replace if you must, do the right operation first. Patient will not be compliant. If it's compounded, which is one of the questions, okay to replace a grade 1, grade 2, be a little circumspect, and grade 3, you should stage. This is the compounded grading of the Castillo.